I'll start recording now so that later I can put this video up on YouTube and you'll have access to it that way. So let's get started. Continuation of the nervous system. Again, like I said, I'm going to backtrack just a little bit because I want to go over the cerebrum and the areas of the cerebrum again. Now, when you look at a brain, you cut the calvarium off, you take the skull cap off, you look inside, you take the brain out. This is what you see. It might not be color-coded so easily, but this is what you're going to see. Most of what you see is the cerebrum. That is basically all of this part here. All of this is cerebrum. The cerebellum is that little area right back there, and you can see part of the brain stem coming underneath. So the cerebrum is full of these folds and these grooves. The folds are called gyri, or singular it's gyrus. The grooves are called sulci, or singular sulcus. And then there's a couple of major grooves that you can see as well. But we divide the cerebrum into areas that are found underneath the bones of the skull, and we name them as such. So we have a frontal lobe of the cerebrum. We have a parietal lobes. We have temporal lobes, and we have the occipital lobe back. So what do each of these do? I believe I mentioned back last week about the frontal lobe helps to determine the benefits and the consequences of future actions. And that does not mean long-term future actions like should I be a realtor or should I be a shrimp boat captain, but those moment-to-moment decisions as well. Should I cross the street now or should I wait for the light? Things that could really make a big difference. And your brain very, very quickly determines the best action to take. So the frontal lobe is one of those things that, one of the newest part of our frontal lobe, the prefrontal cortex, this is really what has made us so successful as a species, to be able to plan and also make those decisions at the same time. The speech center is also located in the frontal lobe, although there's other areas in the brain that are responsible for speech. Just make it simple. The example I usually use for the frontal lobe and the benefits and consequences of future actions is walking down a sidewalk, suddenly coming to an area where a 3-foot chunk of sidewalk is missing, like they're doing construction or something, and your brain has to determine the best way to get from where you are to the next place you want to be, which is continuing your walk down the sidewalk. So it first not necessarily in any order, but it'll determine, well, we could step down into the hole, but then we have to step back out of it again. And in the process, we could twist our ankle, we could get dirty, it's going to require extra effort, we could trip. Then perhaps the brain will think I could jump over the hole, but in doing so, I might not make that leap, I might fall short, I might hurt myself. So it decides, what if I go to the right side of the hole? That would put me closer to traffic, which could be more dangerous. Or I can go to the left side of the hole, but then I have to walk on somebody's grass, which maybe they don't want me walking on somebody's grass. But of all of those choices, going around it, walking on the grass is the best and safest choice. So the brain, as you walk upon this big empty area of sidewalk, the brain goes through all of these different scenarios. You don't even realize you're doing it. But it's going through these different scenarios, trying to determine the best way to get from point A to point B. And it happens just lightning fast. You don't even notice it. All you know is you walk down the sidewalk, you come across a hole, and for a brief moment, you sort of look back and forth, and then you just walk right around and you keep on going. So it's pretty amazing, the frontal lobe, that determines the benefits and consequences of future actions, and also the speech centers are. The parietal lobes, these areas contain areas for interpreting sensory information like pain, vibration, touch. Also, the gustatory cortex is there. So the area of your brain that tastes food is way up in the parietal lobes. The temporal lobes on either side contain the auditory cortex. So sound is interpreted there. And again, when you hear me speaking, the sound coming in is interpreted as human voice perhaps, but you don't actually understand what I'm saying. That information has to go more towards the parietal and then towards the frontal lobes to determine what I'm actually saying and interpreting the words in my sentences. The temporal lobe also houses the olfactory cortex. So you smell, well, I don't want to say it like that, you smell. The sense of smell, how about that, occurs in the temporal lobes of the brain. So off to the sides. Then, of course, the occipital lobe. The occipital lobe way in the back. The occipital lobe is where vision occurs. The visual cortex, yeah, is found here. So the information that comes in as a light information that activates the cells in the retina of the eyes is taken and it's transmitted back across these nerves, the optic nerve, cranial nerve 2. And an interesting thing happens. The information sort of crosses over as it goes towards the back, or at least half of the information from each eye crosses over and then reconverges in the occipital lobe. And that's where you see things. So to remind students that vision takes place in the occipital lobe, I say that it's like having eyes in the back of your head. Because, again, you've probably heard of that saying before. Just a reminder that that's the area for vision. And you can see it breaks it down a little bit more here, but I think you have the gist of it. Okay. What they're showing here, areas of that parietal lobe and that sulcus, that unusual looking person called a homunculus. I don't know if it's written in here. I don't see it. That represents sensitivity of areas in your body. So you can see why places like the lips and the tongue are greatly exaggerated, the tips of the fingers, the hand, or the thumb, greatly exaggerated, because these areas have a great deal of that ability to pick up on fine sensation, whereas some of the other areas, not so much. But you'll sometimes see this as like an actual guy, like an animated looking figure. A very strange looking animated figure with a big head and big lips and big tongue and then big hands with a smaller body. So sometimes it's demonstrated this way and sometimes it's demonstrated just as the person standing there. But this is just a good visual. You know, I'm not going to expect at this level people really understand where all these areas are in the brain, but just the overall idea that some areas of our body have a better ability to detect fine touch, for instance, compared to other areas of the body. And the way it's demonstrated through the homunculus is a pretty good representation, a pretty good drawing. Okay. If you actually watched the review video, You probably heard me talk about consciousness, the state of awareness of oneself, things going on around us. That is just a really good definition. And it's a term that is a simple term that we've all probably heard of. We probably are pretty aware of what it means, but it's difficult to maybe put into exact words. In other words, if I was to ask somebody randomly, have you heard the word consciousness? Most people would say yes. And I would say, well, what's the definition of consciousness? They might struggle a little bit. So the state of awareness of oneself, one's environment, and other humans, I would say other things around us. I wouldn't just limit it to humans. I would include that, but I wouldn't limit it to humans. So good term to know, good definition to know. You're going to see that at some point later on today. Question number 15. No, I don't know that for sure, but you're definitely going to see that. We talked about sleep a little bit already. We talked about the importance of, well, I think we talked about the importance of sleep. We talked about what happens when we sleep. The brain needs to rest. It does, and it does a lot of that during sleep. This is also why when people have a brain injury, the medical professionals might decide to place the patient into a medically induced coma, which is a deep sleep. And most, again, you hear the word coma, you hear somebody's in a coma, you think that's really, really bad. And typically it is. But if it's a bad thing to be in a coma, why would doctors intentionally put people in a coma? Well, again, just like other parts in the body, you sprain your ankle, we don't want you to keep running around the soccer field on it. We want you to rest it. So if there is an injury with the brain, we want you to rest it. And that is a great way of doing it. We talked a little bit about anesthetics before. Oh, we saw some of that already. A couple of good terms, language. Language functions consist of the ability to speak and write words and the ability to understand spoken and written words. So when you hear something like the term aphasias are when there's some sort of language deficit. Let's see. There's actually several different types of aphasias, but an expressive aphasia, for instance, is when the patient can speak clearly or think clearly, but can't speak clearly. So the patient in their head is thinking like what they want to say, but when it comes out, it's sort of mumbled or jumbled. Whereas a receptive aphasia, patient is speaking just fine, but what they hear coming in sounds like a teacher from a Charlie Brown cartoon. That wah 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 wah. So there's a global aphasia that affects all areas. So there's different types of aphasias, but it is some sort of language deficit that causes change in the speech center. And again, this is a term that I think is important to know about. You're going to see this when you're dealing with patients who have things like brain injuries, including cerebrovascular accidents, a CVA. Remember, that's a stroke. Cerebrovascular accident is what occurs when there is a disruption of blood flow to areas of the brain. So that's going to certainly affect things like speech in some occasions. Another good term, there are different parts of the brain that all sort of come together to work dealing with emotions and feelings And that area is called, those parts collectively are called the limbic system. So when you consider what psychologists do, psychologists study the limbic system. They study how people feel and think and all the things that go along with that. But it is not just one area, it's sort of several areas that work together. The limbic system. Good to know. Limbic system. I did talk a little bit about some of the tracks, and I'm not going to go into great detail here, but you can kind of see what they're showing is cut section of the spinal cord, and then parts of the brain stem, parts of the, does it include, it looks like it's just above maybe the cerebellum, and then a section of the brain, and it's just describing this nerve track of how it travels through these areas. And again, if you look at some of these slices, you'll notice that their areas are kind of colored, like some are green and some look like little round brown areas. Each of those represent specialized, I like to think of them as tunnels through which these pathways of nerves travel, sending information to and from the spinal cord and the brain and the cerebellum as well. So I'm not going to go into great detail. I think that's a little beyond the scope of the course. Okay, memory. Memory comes in two parts, short-term and long-term. And for the most part, things have to go from short-term to be moved into long-term. We discussed these things a little bit when we said a person standing in front of you in a line in a Wawa in a grocery store or someplace where they have a name of a construction company on the jacket, and when you're standing there you can read it and you remember the name because it's right in front of you and you just saw it, or you just saw it a moment ago, but 2 weeks go by and you don't remember it anymore. And that's because it is no longer important. Your brain has to determine something is important in order to move it into long-term memory. So let's see. Many of you were not alive back in 2001, or if you were very, very, very small. So you probably don't remember, but for people who are a bit older, when the Twin Towers were attacked as they were, and of course it was all over the news and it was a devastating day. Most people who were watching it kind of remember, even today, exactly where they were, exactly who they were with, maybe even exactly what they were wearing when this was going on. And it's not because they have photographs of themselves that they kind of continue to look back on. It's just because it was a traumatic event. And the brain recognized it as, this is a unique event occurring right now. And so it automatically sort of just jumped ahead and put it into long-term memory. Most things don't happen like that. Most things, in order to put them into long-term memory, the brain has to determine they're important. So how do you make your brain determine something is important? How many times have you met somebody, a relative of a friend or a spouse of a friend, and they introduce themselves, and then 30 seconds later, you forgot their name, or a minute later? Well, it's because your brain said, well, that's not very important. How many times have you studied for a test? hopefully a lot for today's test. But how many times have you studied for a test and then you go to take the test and things you see on the test and it's like, I don't remember this, or I kind of remember him talking about this or her talking about this, but I don't remember what the correct answer is. Where did that information go? You knew it. You knew it when you read it off the page 2 or 3 days ago. Where did it go? Well, it didn't make its way into the long-term memory. So how do you get something to go into the long-term memory? When it comes to studying for a test, it's repetition. You know, our bodies make 2 things more than anything else. All of our cells in our body make 2 things more than anything else. They make energy and they make proteins. Now, you've heard me say that a lot. So for a lot of you, it's kind of stuck in your head because it's like, oh my goodness, why does it keep saying this? But it's kind of stuck in your head. For some of you, I could say our cells make 2 things more than anything else. They make energy and then you'll go, oh, energy and proteins, because those 2 things sort of go together in your head. When you think of energy, you automatically think of proteins because you heard me say energy and proteins, energy and proteins. Now, if you woke up in the morning, looked in the mirror and repeated, our cells make 2 things more than anything else, energy and proteins, energy and proteins, energy and proteins. And every day you did that for a week, you would probably remember it. But what's another way to force it into that long-term memory? Well, consider, for instance, the vertebrae that run through our back, down our back. You know how many cervical vertebrae they are because I made it a little bit ridiculous and I made it a little bit over the top. Rather than just saying 7 cervical, I do this weird thing where I say that there are 7 cervical. And that is unusual, kind of, I don't want to say funny, it's more ridiculous than funny. But it made it stick a little bit more. And then especially when you said it, because then you felt ridiculous saying it. But then it stuck a little bit more. So how do you make that person's name stick in your head when you first meet them? Well, you can make it relatable to something else. If I met somebody's cousin and they said, this is my cousin John, how would I remember cousin John's name? Well, as soon as I met cousin John, I said, hello, cousin John. In my head, I might think, John, like Lennon, where are the rest of the Beatles? And then suddenly in my head, I see him with a little Beatle bowl haircut. And now the next time I run into him, I kind of remember his name pretty quickly because it reminds me of that time when I thought he looked like a beetle, or he sounded very. I made him in my mind look like a beetle, meaning not the creature, not the insect, but like, you know, the Fab Four. So this is how you memorize this stuff. And as I said when I started this, most of what you're going to be learning in this first beginnings of your medical education, for most of you, many of you, is memorization. So what you want to do is you want to make stuff stick in your head. You want to move it into that long-term memory. So you have to make it somehow relatable to you. You'll also notice that when I was talking about the conversion rates and we did that little practice and I gave you note cards and I said, write your weight in kilograms and in pounds so that you could make that measurement somehow relatable to you. And that kind of helps you remember exactly how much kilograms other things could weigh, or how the conversion would go. You would recognize that you're going to weigh less in kilograms than you would in pounds, for instance. Memory is important. Remembering these things is important. It's not just important about getting through this class or passing a test. Those are good, but there's going to be an expectation when you move on to other classes that you already know these things, that this is information that's already stored. So there's not going to be much of a chance for review. It's going to be mostly just building upon what you already know. And so an early memorization of this stuff is incredibly important. So that's why I'm spending a little bit of time on it. Sensory pathways. Again, this I'm not going to spend as much time on because this can get quite involved. And this is stuff that I would hope you would learn maybe in an advanced anatomy class for you guys. But when we talk about sensory versus motor neurons or tracts, just think of it as sensory is like sensation, incoming information, and motor is outgoing information like neurons and signals that are going to tell something to do something. The way I think of it is a motor makes a car move. So motor neurons are going to be the ones that are going to make muscles move, for instance. So anytime there's something that has to be a signal to tell something to do something, like a motor to make a car move, I think of motor neurons. And anytime I hear something about incoming information that the body or the brain has to perceive, then I think, well, that's like your senses. So that would be a sensory neuron or sensory pathway. Was that it? Okay, good. So broad overview of some of those pathways, which again are good, but quite detailed for this level. And here the detail continues. The peripheral nervous system. Remember, the central nervous system is the brain and spinal cord. So all of the nerves that branch off of the brain, all of the nerves that branch off of the spinal cord, and all the branches off of those branches all fall under the category of peripheral nervous system. We said the peripheral nervous system also has an autonomic and a somatic portion. The somatic portion is voluntary. The autonomic portion does things automatically, and the autonomic portion is subdivided into the sympathetic and parasympathetic divisions. Parasympathetic is what we live in every single day. Most of our lives are in parasympathetic mode, the rest and digest mode, whereas if we're being chased by a bear, it switches over into the fight or flight sympathetic. 31 pairs of spinal nerves. So as the spinal cord descends down through all the vertebrae, and we saw pictures of this already, branches come off from either side. And those branches are sending information out to the body, and they're having branches come into the body with information. There are cranial nerves, which are going to be coming off of the brain, and these are going to mostly affect the head, neck region. There's one, however, that does travel. It makes its way all the way down into the abdominal cavity. But for the most part, they're at the head. 31 pairs of spinal nerves, we number them, connect directly off the spinal cord. So I'll just show you a picture first so you can see them. Now, for the most part, they're easy to remember how many pairs of spinal nerves there are, because there's going to be a pair of spinal nerves that come off under every vertebra. So in the thoracic region, for instance, there are 12 with a T, thoracic with a T, vertebrae, which means there are going to be 12 sets of spinal nerves. The lumbar region has 5 big vertebrae. So there's going to be 5 sets of spinal nerves. And right now you're thinking, well, wait a minute. What about the cervical region? Because the cervical region has 7 vertebrae. But according to this, there's 8 pairs of cervical nerves. Well, that's because the first set, C1, actually comes out above the first vertebra. So there's an extra pair of cervical vertebrae. And then they will often connect up into these groups, the cervical plexus and the brachial plexus. And you see how they come together and then sort of branch back off again. And that can be very useful in determining things like injuries, because we'll know that if an injury is in a brachial plexus, for instance, it'll affect the shoulder and the arm, even into the scapula. Whereas if it's just one nerve injured in the arm, it's not going to have the same effect. So it becomes useful that way. Five sacral vertebrae. Of course, there are 5 fused together, but not surprisingly, there's going to be 5 pairs of sacral nerves. And then you can see how they come together into a much larger nerve to travel down the leg, for instance. Also, right here, right about lumbar vertebra 1, you'll notice the spinal cord, which had previously become coming down as a one long big cord, kind of splits off. And it resembles a horse's tail, which is why it's called the cauda equina, which is Latin for horse's tail. Now, it still has the branches of nerves that come off, but it just takes on this very different shape. So all the way down through those vertebrae, that hole that is in each vertebra is a foramen, singular, and not surprisingly called a vertebral foramen, all the way down. Oh, there it is. You can see right there how it travels down. Notice how the spinous process coming off the back of the vertebra, each vertebra helps to add protection to that spinal cord. I didn't include the coccygeal pair. Now, I think it had to have been week 2. We were talking, or even week 1 or week 2, we were talking about direction planes and directional terms. And I said that things that are more towards the front of the body are anterior. Things that are more to the back of the body are posterior. And I also mentioned that another term for anterior is ventral, and another term for posterior is dorsal. The reason why I mentioned that is because here's an example of where they use those alternative terms. So you kind of have to know that the ventral root of these neurons are going to be more towards the front of the body. The dorsal ones are going to be more towards the back of the body. And you'll see something else that's, I think, interesting. The ventral roots have motor neurons. So those are outgoing messages to go tell something to do something. The dorsal root has incoming messages. And those incoming messages are going to be the sensory messages. Some nerves can have both, and we'll see this a lot when we get to the cranial nerves as well. We're not going to talk much about the rami because that is, again, a little more than I want to talk about. Let's see. Of this part here, the one that I want you to kind of know about, and we're going to hear this again, is the phrenic nerve. Notice phrenic spelled with a PH. The phrenic nerve is an important nerve. You may recall me discussing a dome-shaped muscle that separates the thoracic cavity from the abdominal cavity. That dome-shaped muscle is called the diaphragm. That dome-shaped muscle is important because when it contracts, meaning it shortens, becoming less dome-shaped, more towards a flatter shape, that's going to change the air pressure inside the lungs as compared to the outside air, and air is going to come rushing in. In other words, that's how we breathe. That's how we breathe air into our lungs, because that diaphragm contracts. Well, the diaphragm is a dome-shaped muscle. And I told you before, in order for a muscle to do something, it needs to be told to do something, which means a signal has to come down a nerve, in this case, the phrenic nerve, what innervates the diaphragm. This is the one that's going to send that signal down to the diaphragm and say, okay, now contract. Well, because of the origin of the phrenic nerve, up near the esophagus, at one point near the esophagus, when a person eats something or drinks something that irritates the esophagus, that irritation can be transferred to the phrenic nerve. So what happens is the phrenic nerve partially depolarizes, and that small depolarization travels down the phrenic nerve and sends a brief, quick little signal to the diaphragm, which causes the diaphragm to quickly do a little contraction. And we call that a hiccup. So how do you get rid of hiccups? Well, there is a brief little weak signal being sent down the phrenic nerve telling it to quickly and briefly and slightly contract. This electrical signal just continues to propagate and send down that nerve. So what we want to do is we want to override it. We want to override that weak little partial signal with a big main normal signal sent down that nerve. We want to override it so it will reset. The way we do that, the best way to do that, is by holding our breaths. Holding our breath, not breaths, it'd be breath, one breath. So if you hold your breath as long as you possibly can, like until you're about to pass out, and then suddenly you have to take a deep breath in, there's a big electrical signal that goes down that phrenic nerve. That big signal will hopefully override that little intermittent signal and reset that membrane so that depolarization, that little slight depolarization stops and the hiccups go away. Some people say, well, I heard that if you drink water, that makes hiccups go away. Well, try breathing while you drink water. No, don't try that. Don't try breathing while you drink water. That'll lead to things like suffocation. So don't do that. But in other words, when you're drinking water, you're not breathing. In other words, you're holding your breath. It's still just another way to hold your breath. So a little fun fact regarding the phrenic nerve. But we will see this one again when we talk about the respiratory system. So FYI, phrenic nerve. I talked a little bit about the brachial plexus already. I'm not going to talk about the lumbar or sacral plexuses. We're going to go right to the cranial nerves. 12 pairs of cranial nerves. They have names and they have numbers. Their numbers are Roman numeral numbers. So you can see that in the parentheses. They can be motor neurons, they can be sensory neurons, or they can act as both. So we can start with the olfactory nerve, which is cranial nerve 1. And you can see how that is going to be a sensory nerve because it is going to accept the information coming from the crystal galli or through the crystal galli in the nose, was picking up on smell, taking that to the temporal lobe of the cerebrum eventually to interpret what you're smelling. Olfactory nerve, cranial nerve 1. Now, I should preface this by saying, do you need to know these cranial nerves? There's a couple that you should know. Would it be ideal if you knew all of them? Certainly, that would be wonderful. But is it required at this level? I would say no, but I would say there are definitely a few that you want to know about. One of the ones you want to know about is cranial nerve 2, the optic nerve. You see that here, cranial nerve 2, the optic nerve. Now, the way to remember that cranial nerve 2 is the optic nerve is by looking at the Roman numeral 2, because each Roman numeral 1 looks like a capital letter I. So in this case, there are 2 capital letter I's. So there are 2 I's. So the optic nerve is cranial nerve 2 with the 2 I's. That's how I always have remembered the optic nerve. But that is a good one to know. That is one I definitely suggest. That one too is a sensory nerve. And then let's see, oculomotor nerve. Well, that tells you right there in its name, motor. This is cranial nerve 3. Oculomotor nerve, it's going to have something to do with moving the eyeball. Motor. Let's see, cranial nerve 4 up here, trochlear nerve. This is also a motor neuron that is going to clearly, well, as I say clearly, but it is a motor neuron. It's going to involve movement of some kind. Cranial nerve 5 is the trigeminal. There it is, the trigeminal nerve. I would definitely recommend knowing trigeminal nerve 5. This one is both a motor neuron and a sensory neuron. And you'll notice the distribution, which continues down along the jawline. This nerve is the nerve that innervates the temporalis muscle, the masseter muscle, and the medial pterygoid muscle. Those 3 are all involved in closing the mouth. It's also the nerve that innervates the lateral pterygoid muscle, which is the muscle involved, the main muscle involved in opening the mouth. So that's why this one is a good one to know, trigeminal. And a way that I kind of remembered this is trigeminal nerve, cranial nerve 5, and the Roman numeral 5 kind of looks like a triangle. So triangle, trigeminal. That was how I remembered it. Okay, the abducens, where are we? There we are. Abducens nerve, cranial nerve 6, is also a motor nerve. I have to go through my mnemonic to remember all of these, which I'll tell you later on, sort of. Cranial nerve 7, the facial nerve. This is also a good one to know about. This one is a motor and sensory nerve. It does both also. This is the nerve where inflammation can occur. And when inflammation occurs with this nerve, this can cause sort of a paralysis on one side of the face. This you'll hear of called Bell's palsy, where one side of the patient's face will kind of droop. inflammation of the facial nerve causes this. Not really sure why it happens, but because in medicine, if we don't know what causes something, we blame it on a virus. Because if it was a bacteria, we'd be able to see it. It's big enough. If it was a fungus, we'd see it. If it was a parasite, we'd see it. If it was a protozoan, we'd see it. But if it's happening, we don't really know why. We just tend to say, well, it must be a virus. That's why if a patient comes in the emergency department with Bell's palsy, we treat it with prednisone for the inflammation and acyclovir for the antiviral property. Okay, that was facial nerve 7. Vestibulocochlear nerve, cranial nerve 8, also known as the acoustic nerve. Vestibulocochlear nerve, also sometimes called the auditory nerve. So I guess you can hear it that way as well. This is a sensory nerve, incoming information about sound, for instance. And you can see here, this snail that you see is not a snail. We do not have a snail in our head. This is actually in our inner ear. It is called the labyrinth. And it is made up of 3 parts we'll see later on. The vestibule, sort of in the center, the semicircular canals, which are important with balance and 3-dimensional posturing, and then that cochlea, that snail shell part. And that is where these little tiny filaments are located, suspended in a gel-like liquid. And they vibrate when sound comes in. And that vibration of those act as the signaling, which goes to the vestibulocochlear nerve, which goes to the auditory cortex to interpret a sound. Vestibulocochlear nerve. That's a good one to know about eventually. That was cranial nerve 8, right? Cranial nerve 9 is the glossopharyngeal nerve. This is both. Let's see. Yes, this is both. Again, I'm going through my mnemonic to remember which are sensory, which are motor, and which are both. So this does both. As you can see it innervating the mouth. Cranial nerve 10 is definitely one I would want people to know about, because look at where it goes. Remember I said that the cranial nerves basically innervate the head and neck regions, but then this one goes all the way down eventually into the abdominopelvic cavity. And vagus means, it's a Latin word for wanderer or wandering. I think it's wanderer. So this is kind of a good one to know about because it's the oddball. It's the one that sort of goes down into the abdominal cavity. Let's see, and vagus is also both. It does both sensory and motor. Okay, the accessory nerve, cranial nerve 11. This is This is a motor nerve as well. And then finally, the hypoglossal nerve, cranial nerve 12. This one is mostly motor, although I think it can do both. I think it has the potential to do both. If I remember from reading, it does have a potential to do both, but I think it's mostly a motor nerve. So for these 12, I would say the ones that you definitely want to know about is the optic nerve, cranial nerve 2, and that one's kind of an easy one to remember. Optic nerve, cranial nerve 2, two eyes, two capital letter eyes, cranial nerve 2. Trigeminal nerve, cranial nerve 5, which does both. What else did I say? A facial nerve, cranial nerve 7, because it's associated with Bell's palsy, and the vagus nerve. I would say those would probably be the most important for it. And eventually the vestibular cochlear nerve would be a good one to know about as well. I think, again, at this level, trying to get everybody to memorize all of these is a little bit unrealistic and a little unnecessary. We'll talk about the optic nerve again when we get into the head, ears, eyes, nose, and throat. We'll probably talk about the vestibular cochlear nerve again, which is why I said that's a good one. So there's a couple that I definitely would say know about. And the optic nerve is probably one that I would test you on eventually or quiz you on or something. That one's kind of easy. And it's a good start in memorizing all of these. Maybe even the vagus nerve. So how do you know which ones are sensory, which ones are motor, and which ones can do both? The mnemonic that we used in medical school, starting from cranial nerve 1 through cranial nerve 12, S for sensory, M for motor, and B for both. So if you consider the mnemonic, some say money matters, but my brother says big belts matter most. I'm going to use belts for that. Some say money matters, but my brother says big belts matter most. So for every word that begins with an S, that's sensory. Every word that begins with an M, that's motor. Every word that begins with a B, that's both. So that was the mnemonic we used. And obviously I still use it today. Okay, that's what this is here. I wonder if they give you a mnemonic, but they did. You know, I think, yeah, before we get into this, let's stop for a minute. Yeah. Oh, they don't do that. Okay. Any questions about some of those? Cranial nerves, cranial nerve 2, optic nerve, cranial nerve 5, trigeminal nerve, cranial nerve 7, facial nerve, cranial nerve 8, vestibular cochlear nerve, and cranial nerve 10, the vagus nerve. If you were going to set your mind to memorizing those, I would say start with those 5. And if you're going to start with just 2, I would say cranial nerve 2, the optic nerve. That one I guarantee you're going to see at some point in time on a quiz or a final or something. And then the vagus nerve, cranial nerve 10, because it's weird. But those 5 would be a really good start. The 2, definitely, I would say you'll want to look into. Get those flashcards. Yeah. No questions? Or are you all just too busy right now watching YouTube videos? You know, I'm going to check to see how many views it has right now as compared to an hour from now.
No, I'm going over all the notes I took for this exam.
Great. Okay, thanks for your honesty. All right, let's take a break then. We'll take a bit of a break. Pause. Any questions? Good, bad, indifferent. Any questions at all? No. Okay. All right, so let's get back to where we were. So you should be able to see my screen in about 5, 4, 3, 2, 1, 0. Now, I will tell you that I want you to hear these words afferent and efferent over and over and over again, because they'll come back again in different contexts. We talk about blood supply, for instance. So I kind of want these words to become more and more familiar. With regard to the nervous system, the afferent division is the sensory division, the incoming messages. Those are the messages that are arriving in the spinal cord and the brain. Efferent is all the outgoing messages, sending messages out. Those are the motor division. So those messages are exiting the spinal cord or brain. Afferent, arriving, efferent, exiting. Afferent with an A, arriving, efferent with an E, exiting. I said that the somatic division is stuff that is voluntary. So think about waving your hand, all the things that are involved in waving your hand. You're doing that intentionally, although you might not actually think, okay, first I have to activate my deltoid muscle to raise my arm up sideways, then I have to activate everything from my tricep muscle to my brachioradialis muscle, maybe my abductor muscles if I wanted to. So you're not going through that whole process, but you are thinking, okay, I want all those things to occur. So you're making it happen. That's voluntary. Whereas autonomic does things automatically. But some common reflexes, and there's two specifically that I want you to know about. The knee jerk or patellar reflex, you've seen this before, tapping just below the patella, just below the kneecap. It is going to stretch that patellar tendon and the quadriceps femoris, which is going to cause this arc to occur. As those stretch receptors are activated, it sends a signal back to the spinal cord. There's an interneuron involved, which is going to then eventually send a message to a motor neuron that is going to tell the muscle to contract, which is going to cause you to punt your foot away. In other words, you're going to cause it to kick away. This one, I'm sure you've seen before using the little reflex hammer. You can try it. You don't actually have to use a hammer. You can just use your fingertips a little bit, and you can see how that would work. But it's just below your kneecap, just below your patella. You can feel that area. Don't hit it too hard. And for my sake, do not use a hammer like a real hammer. That'll hurt. There's a reason why that little reflex hammer has a rubberized portion to it. Do not use a steel hammer to try this. Then, this one I want you to hear about. This is an important one, the Babinski reflex. The Babinski reflex. Babinski. Now, if you've ever seen a movie or a TV show where a person was in a car accident, the paramedics are wheeling them into the emergency department, and there's a doctor or nurse, somebody there is going to grab something like a reflex hammer, and they'll use the back end of the reflex hammer. They'll grab the patient's foot, like at their ankle, and then they'll take the reflex hammer, starting from the patient's lateral heel, so from the outside of the heel on the bottom of their foot, they will sort of draw, they'll use that back of the hammer to, I guess, move up along the lateral side of the foot. And what they're going to watch for is the toes. Because what we want to see is we want to see the toes curl under, like curl downward. That is normal. And normal is negative. A normal Babinski is a negative Babinski. If they stroke on the lateral side of the foot, starting from the heel all the way up towards the toes, and the toes go in the opposite direction, in other words, they dorsiflex upwards and fan out, that is positive. That's a positive Babinski. That is not normal. This could indicate a problem with the spinal cord, for instance. So that is a good one to know about, because you'll see that happening. By the way, in children, it's reversed. Normal fans out, abnormal curls down. And that is until they are about 18 months, I believe. You see it sort of switch over, when they're walking. So of these, the two that you kind of should know about right now is the Patellar Reflex, because it's familiar. You've seen this one, you know about it. And the Babinski, probably again, because you've seen it in movies or TV shows. A lot of people think that they're checking to see if the patient has feeling in their foot, like if they can feel it. And that goes hand in hand. They could also be doing the same thing at the same time, saying, hey, can you feel this? But what they're really doing is you watch them, they'll stroke it up the lateral side of their foot from the heel up. And they'll be watching for the toes curl. I wonder if there's a video on that. Check. Okay. Major functions of the autonomic nervous system, the ANS, involuntary, regulate heartbeat, smooth muscle contraction, meaning like the muscles of the intestines or the blood vessels. It's inside the walls of those that are going to change the way things move through them. And glandular secretion. Or even the muscle in the iris that controls the iris. That'll cause the pupil to constrict or to dilate. That is autonomic, of course, because you don't have the ability to control those things on your own. You cannot just sit here and make your pupils dilate. It could be kind of creepy. The motor pathways comprise two efferent divisions. Sympathetic division, fight or flight. Parasympathetic division, they say rest and repair, I say rest and digest. Most of our life, we live under the parasympathetic control. It's only when we have to put up a fight or run away do we switch over into sympathetic division. I prefer run away. But again, think of it as most of your life, parasympathetic division, everything's nice and calm, or being chased by a bear, sympathetic division. And remember the rule, when you're being chased by a bear, you do not have to be faster than the bear. You just have to be faster than the person next to you. This is a cut section of the spinal cord. Remember, the spinal cord has the gray matter on the inside and sort of an H shape, and the white matter on the outside. That is the opposite of the brain. The brain has the gray matter on the outside, the white matter on the inside. To remind you, the gray matter is made up of the cell bodies and the dendrites. And the white matter is made up of all of those axons that are surrounded by the neuroglia cells, in this case, the oligodendroglia cells, that myelin insulation. So when you see all that white matter, that's actually what you're seeing. You're seeing axons surrounded by myelin insulation, all packed together. So just a good reminder. Also, you can see that these motor pathways in the red arrows, they are extending from the anterior, or the also known as the ventral portion of the spinal cord, because the motor pathways, that's the efferent, they're going to be sending signals out. That is in the front part of the spinal cord, the ventral or anterior portion. And the dorsal portion has the incoming signals. It doesn't show them here, but you can see where the branches come to the more towards the back of the spinal cord. Now, why do I bring that part up again? Why do I mention that again? Well, remember, things like pain are incoming messages. So those are incoming messages to the back, the posterior aspect of the spinal cord. And if we want to minimize those signals, we can introduce an anesthetic agent into the posterior aspect in that area, that unique area around the spinal cord that is above the dura mater, called the epidural space. And when an anesthetic agent is introduced into that epidural space, it is mainly going to affect these nerves coming into the back, the dorsal part of the spinal cord, which are incoming messages. And you can see why when she is in labor and delivery, we would want to introduce that anesthetic agent into that posterior portion so that the incoming messages of pain and discomfort are completely eliminated, and the birthing process then becomes much more pleasant. I'm pausing for all of the comments to come rushing in of, no, it doesn't. I know. So, why is it that some women have had those anesthetic agents introduced into the epidural space during labor and delivery? I know you just want to call it an epidural, so from this point forward, we'll call it an epidural. Why is it when those patients have that epidural during labor and delivery, some of those patients say it was wonderful, it worked so well, and other patients said, oh, it didn't work at all? And some patients said, well, it didn't work with one, they had to give me another one. And perhaps the bigger question is, why are you surprised? Because remember, people are different. So if I have a headache, I take 2 ibuprofen and that works perfectly. When other people have a headache, they have to take 4 ibuprofen. When other people have a headache, ibuprofen doesn't work at all. They have to use something different. Every one of us knows this. Every one of us knows that ibuprofen, the Advil, whatever brand name you want to use, doesn't work the same for everybody. So why would it be any different when we're administering anesthesia, when we're introducing an anesthetic agent into an epidural space? Of course, it's not going to work the same for everybody. That should be the expectation. If it worked perfectly the first time, that's great. That's exactly what we're hoping to accomplish. But it doesn't mean that it will. And I hope that makes a little bit of sense. I hope you can sort of sit back now and go, oh, you know what? Now that makes sense. That's what I'm trying to do. Okay, so this here is one of those areas where I would say I would save this for the advanced anatomy class. Although it's good to be able to see where these different pathways that are coming from the sympathetic versus parasympathetic that are sending these signals out. I think it's good to be able to see those things. You can tell right away that there's a lot going on here, and trying to take all this information in at once or even at twice might be a bit of an overload. So I think at this point, I would just like for you to see it, take a quick look at it, read through some of those things, and not much more. Okay. Patellar reflex, again, that's a good one to know about. Achilles reflex, not as much. But here is that Babinski test. Remember, we're going to take the back end of that percussion hammer, or you could use like maybe a Sharpie, the back end of a Sharpie or something, and drag it up from the lateral heel up and to around the toes to watch them change. And we didn't talk about the abdominal reflex, but that's okay. What did I want? Oh, the fun fact here. At least 75% of all parasympathetic preganglionic fibers, in other words, the first ones, travel in the vagus nerve. So, oh, there's a figure. That just tells you there's a lot going on in that vagus nerve. One more reason why vagus nerve, cranial nerve 10, kind of a good thing to know about early on. Oh, I didn't pass this up, I didn't mean to. Okay. Autonomic neurotransmitters, remember, those are the chemicals that go from the end of one neuron and bind to receptors onto the next neuron. And the ones that I want you to hear about: norepinephrine, acetylcholine. Now, I want you to hear about acetylcholine because we've already talked about acetylcholine. Acetylcholine is that one involved in muscle contraction. And that's an important one to know about. Acetylcholine involved in the muscle contraction. Remember, the signal comes down the nerve, down the neuron in the form of an electrical current, has to be changed into a chemical signal. And that chemical signal is acetylcholine, which is going to bind to receptors on the muscle fiber, changing the permeability of the membrane, allowing sodium to come in, eventually allowing more sodium to come in, which causes the depolarization, the change across the membrane on the inside of the muscle fiber, which eventually causes the release of calcium, sliding filaments, et cetera, et cetera. And then norepinephrine. Norepinephrine is another neurotransmitter you'll hear about. Different from epinephrine. Epinephrine is a hormone. Norepinephrine is a neurotransmitter. And there's just one methyl group that is what makes the difference between the two. I think we talked about methyl groups, CH3s. I think we did way back in the chemistry part. The epinephrine, the what people would call adrenaline. You've probably heard of that. That has the extra methyl group. So breaking them down, you hear the terms adrenergic fibers and cholinergic fibers. Adrenergic fibers are the ones that are going to be releasing the neurotransmitter norepinephrine. Cholinergic fibers are the ones that we've kind of talked about a lot, releasing acetylcholine. So that's terminology that I want you to hear. This is not the time for me to test you on adrenergic and cholinergic fibers, but they're definitely terms that I want you to hear about, so that when you do go into more advanced anatomy and physiology and some of the other classes to come, at least the terms adrenergic and cholinergic will be familiar. You will have heard of them. And if you know, if I put them on a test, I would make it simple enough that all you had to know was adrenergic release norepinephrine, cholinergic release acetylcholine. I would say just put that on flashcards or note cards and just memorize that part of it. But not for this class. Again, that is something I would definitely have in the advanced anatomy. I actually did have the advanced anatomy class, stuff like that. Good images, just to kind of remember that we have a neuron, the nerve cell, that has an electrical signal that travels down, which then changes into a chemical signal, things like acetylcholine. That chemical signal crosses that space called the synapse. Well, the space itself is called the synaptic cleft, although you'll sometimes hear me call it the synaptic gap or synaptic space, or sometimes just synapse. But the synaptic cleft is the space in between, and that is where the neurotransmitter is released to meet the next neuron. Now, understand that these spaces are incredibly small spaces. They will look like they are touching even under a microscope. They'll look like they're attached, but they're incredibly small spaces. Now, another thing I want you to remember about these spaces, when it comes to in the brain more so than the spinal nerves, but in the brain, when we do things to change the way neurons are reacting, and meaning the way the brain is acting, the way people are thinking, everything occurs at this space right here. We either alter the receptors so that they cannot have this neurotransmitter bind to them anymore, or we alter the cleanup guy. Remember, we had that Pac-Man acetylcholine esterase in the muscle. We can block him and allow that neurotransmitter to stay in the space longer. I think we did talk about that with what was the example they gave us? Selective serotonin reuptake inhibitors, I believe, the SSRIs. But everything we do that's going to alter the way that person thinks is occurring at these spaces, in this space. So just something to kind of remember as a big picture. Okay, I don't think I want to talk about that. I think, let's see. Yep. Oops, sorry. I think that was it. Yeah. Yeah, I think that was it. I don't want to go into anything else. Yeah. So, like I said, now we're going to come up a little short, and I hate wasting time. But you bring up a really good point. The time's not going to be wasted if you're going to use this. I'm going to say hour because I planned on lecturing till noon, but I was really sort of determining how much new information I wanted to get into, if any. But I think that what I'm going to do is, let me get back to you here. Sorry. so you can actually see me again. Dang it. I forgot to do that. Okay. So what I'm going to do is stop lecturing now, give you an hour, because that hour, like I said, I was planning on going till noon, but I'll give you that hour to study, and then I will meet you at the school at 1 o'clock. So depending upon travel time, you might have a little less than an hour, you might have a little more than an hour, but that's what we'll do. Are you ready?
Nope.
I'll take that as a yes. All right.
I have a question.
Yes.
Do we need anything else besides a pencil?
Just be in uniform. I think I mentioned that because you asked. I'm glad you did. I don't think so, because it is 75 questions long. So if we would normally have class till 3, I would normally give about 90 minutes to take the test. And considering my time frame of people arriving is between 12:30 and 1:30, for some people, it might take them all the way up to 3 o'clock. Please understand, if it takes you longer than that, if it's, going up to almost 3 o'clock and you still have 10 questions to go or something, I'll wait. It's not, you don't have to just rush or quit or whatever. I'll still be there. So I'm not going to say we have to finish by 3 o'clock or else. I will still be there. So, but I won't be planning on doing much of anything else, because I know that some students are going to take a little more time. Good?
Yep.
You can bring rabbit's feet if you find them to be lucky, 4-leaf clovers, any type of cereal that ends in charms. I think that would be probably something you could bring. That's all I got. All right, I'm going to end recording right now.